Three, two, we are live now.
Okay. Good evening, dear viewers in India and those abroad. Thank you very much for joining on yet another pre-conference webinar for the ISSICON, which is the International Spine and Spinal Injuries Conference, which is to happen in just about a month's time in Chennai at the Hyatt Hotel. So this meeting is a combined meeting of the Spinal Cord Society of India, the AO Spine Knowledge Forum for Trauma, and the Asian Spinal Cord Network. And this is being organized by Kaveri Hospital and Hamsa. So the meeting is happening at the Hyatt Hotel for 3 days. The conference for the first 2 days is the main conference, followed by workshop on the last day, which is November 2nd, the Sunday. So this meeting is going to be attended by approximately 400 to 500 delegates, which consist of spine surgeons, neurologists, neurosurgeons, and also rehab specialists, which is rehab medicine, physiotherapist, occupational therapist, peer counselors, psychologists, consumers, researchers, and scientists. So we welcome you all to Chennai, where tradition meets innovation. South India, which is popular for many things culturally, and also is a great city to be in at this time of the year. The weather is fantastic. So as I said, this meeting is going to be one of the largest of ISSICON meeting and is the 25th year of the conference and the society. So we have more than 50 international delegates from all over the world, and about 150 national faculty and the delegates. So these are some of the big names and in spine in India, from every city, every corner of India, both from Chennai, and it's also organized by the Chennai Orthopaedic Spine Society and the Chennai Neuro Association, who are partners. We have big names in spine trauma like Alex Vaccaro, who's coming in person, and another series of other names of people who are coming as part of AO delegation for the conference. So we look forward to exchanging a lot of experience and knowledge from various people. The Spine Bootcamp for Trauma will be on the November 2nd, the last day, where we have a lot of hands-on workshop and practical discussions about various things related to trauma that we use in our operating theatre. So this will be very interesting and definitely a must-do. So today I would like to invite you to this session. This is our third webinar, and we still have another 4 more to go before the conference. And it's my pleasure to invite Dr. Bronek Boszczyk, who's from Germany. He's a consultant spine and neurosurgeon, dedicated his career to spine surgery. He's my mentor, and I'm very proud to say that I've been trained under him, with him, and in Nottingham, and he's moved from Nottingham now to Germany. And so he is a specialist in pretty much everything in spine. So A to Z of spine surgery is his specialty. But he has a lot of interest in deformity, and currently is doing a lot of work with pediatric deformity and pediatric work. So he's an excellent mentor, a great trainer, excellent speaker, and he's been very active in AO. And he's also the director of NSpine, which has been there for about a decade, where he does international conferences in all over the world. And recently it's happening in South America. And probably, Bronek, you can share a slide if you want about the next NSpine meeting. And regular meetings are also happening in London, and I just recently attended in July this year. So he's a great resource, and he's going to share us his experience of pediatric cervical trauma, principles, and evaluation. Thank you, Bronek, for taking time off between your clinic. So the format is you can finish your talk, and then we will have a little discussion with our panelists, and we'll pose any questions that come from the group. Thank you so much, and I'm just going to log off.
Thank you so much, Bala. It's been a pleasure to have worked with you for so many years now, which is, gosh, approaching a decade and a half.
Yes.
And thank you for the very kind invitation. It's an honor to be here, and I'm delighted to share well, which is not only my experience, this is actually a cumulative experience because fortunately, pediatric cervical injuries are not that common. So this is an amalgamation of experience of various people that have been kind enough to share their wisdom with me. And I've put together and I'm happy to share with you. So the cases and images include cases from all these various colleagues that I've worked with over the years who are excellent teachers and clinicians in their own right. And some of the books which you'll see pictures from are these books, which are all excellent textbooks and classics of spine in their own right. Now, this is a recent study which more or less highlights the problem which we are facing, and that is that pediatric cervical injuries are rare. This is a German multi-center study published in 23, and they looked at 6 spine centers and the data collected on pediatric injuries over 7 years. And over 7 years, they had 22 injuries under 7, they had 24 between 7 and 10, and overall, the total number under 10 is 46. Now, 40% had a head injury, and only 34, which is 16%, required surgery. Now, if you divide this by the number of centers, then that's roughly 1 surgical case per year per center. That's not a lot. And even if you split it into the age groups under 7, it becomes even less. So 22 kids under 7 across 7 years in 6 spine centers. It's a pretty low number of cases that any spine center will see. And then if you dilute that across the number of surgeons that are available, the experience is very limited. So large countries like India will have more experience if you pull these cases. For small countries like Switzerland, Austria, the experience will, of course, be quite limited. Children not equal to children. The risk of a cervical injury is higher the younger the child is. And this has something to do with the mass of the head in relation to the rest of the body. So small children have very heavy heads. They do not have very well developed muscle. And of course, they have a lot of growth zones, a lot of cartilage, which is susceptible to injury. So the age-related risk goes up the younger you are. Now, of overall C-spine injuries, if you take them all into account, between 1 and 10% of C-spine injuries are pediatric. So they're not very common. The majority of pediatric injuries are cervical. So kids tend to get cervical injuries. In the under 8 group, the age group under 8, it's mainly upper cervical spine, the same as Skiwara and kids with neurological deficits. And of course, most of these have ligamentous injuries. From about 12 years on, you see adult patterns. So they're not, if you have a child aged 13, 14, 15, they're not pediatric injuries which are comparable to these younger children. So the younger child is very much a separate entity in this. Now, one of the things which is often missed in children this age, it starts outside when the children are rescued or brought into the hospital. And this starts with positioning the child. A child has a big head, and often plain positioning will already flex the neck. So typically in smaller children, it's recommended fold a towel, fold something, put another torso to prevent the neck flexion. The other aspect, as we've pointed out, is that the ligamentous injuries in the younger child are very common. So there's a very high incidence of distraction injuries. So rather than try to get stiff necks onto these kids, sandbag immobilization is much better than a hot collar. So avoid distracting these kids. Most will have distracting injuries, especially if they are the younger age group. And I will show some examples of this. Now, what helps in the understanding of cervical injury patterns, and this is just going to be a very brief overview. I'm not going to go into great detail, but what needs to be appreciated is that from the original sclerotomes, so if you look at the ProAtlas C1 and C2, you can see that the top part of C1 and the top part of what becomes the odontoid are from one unit. The C1 body and the odontoid are from a second unit, and the body of C2 is from a third unit. And this explains some of the developmental anomalies you get, but also the growth plates that you see. So this is a color illustration hereof, and you will see that C1, C2 form the atlas, and the main body of the odontoid and the main body of C2. And that the very tip of it, you have the occipital condyles, you have the tip of the odontoid. These are from the proatlas, and they don't always fuse together adequately. And certainly this is where you see the cartilaginous areas, which are the areas of least resistance in trauma in children. So when looking at the imaging of patients, the important thing is to assess in these children where the injuries are. This is very difficult in the very younger age group, and you will see an incomplete ossification. The children typically have a widened atlantodental interval, and they all have an increased prevertebral space. So looking at the soft tissue in kids is almost obsolete. It's very, very hard to detect anything. And the bony structures which you see in the X-rays are typically not the structures which are injured. It's typically the growth plates or the ligamentous insertion. This is an example of a child which was X-rayed after a fall from a sofa, and it's very hard to make much out from this X-ray except that the alignment is good. Now, the fusion of the growth plates usually takes place between 5 to 7 years of age. Before this, there's a physiological cleft, you have physiological fissures according to the growth areas of the spine. So the C2 synchondrosis, which is in the middle, is a typical finding of the odontoid. Often this is mistaken for fractures. And the atlas actually is quite variable in ossification center. Sometimes you have multiple ones across the arch. These are not fractures. These are typical growth planes. The neurocentral synchondrosis of the side, which is at the base of the growth of the pedicle, this is sometimes also seen as a pseudofracture. It's not. You have these very prominent in the body of C2. And in fact, some of these, if they fuse early, can lead to congenital malformations of the upper cervical spine. A minor angulation, and if you remember the fusion area C2, C3 sclerotomes, this is where you get the kinking in the vertebral body. This is physiological. This is often, especially if there's a regular soft tissue shadow, this is a normal finding, and a radiolucent synchondrosis can be physiological. Now, on occasion, MRI is required, and an MRI will prove this whether there is a genuine injury or not, but radiologically, this is often a normal finding. Same as the pseudosubluxation of C2 and C3. Now, this is a very common finding, and it needs to be differentiated from a hangman fracture, which is a very different entity. The wedge shape of the vertebra, together with the rather longer lever arm of the C2 vertebral body, lead to the pseudoarthrosis and not a pseudosubluxation. And often it's due to the positioning of the child when the X-ray is taken. In this example, you can also see that the prevertebral soft tissue shadow here is of a normal width, and there's a typical step off here to the subaxial spine. So this is a normal finding. There's no hematoma. There's nothing to that effect. There's a slightly widened atlantodental interval, but if you look at the spinal laminar line, these are all perfectly in line. So in order to assess these and destructive injuries in the ligaments, a number of investigations need to be performed. And I'll come back to evaluating the hangman's fractures in a little while. Most of the children in the young age will suffer from distracting injuries. These can be fatal and frequently are fatal. This is due to the alar ligaments being attached to this very cartilaginous part of the odontoid, as we explained in the embryology early on. This is where the alar ligaments attach, and they can avulse very easily from the tip of the odontoid. The alar ligaments are basically what holds the head.
Hello, Bronek, can you hear us? We've just lost you here for a minute. Soma, can you hear?
Yes, sir, I can hear you. His connection, I think, has got disconnected, sir. We have to somehow contact him. I think he's offline now.
Okay, so I hope he will. I think
Yeah.
he'll be connected. Yeah.
Yeah, probably he'll be connecting.
So the viewers, please do ask questions. As it was suggested, it's a very, very rare thing, and probably in your lifetime you may come across a few cases if you are lucky. So if you have any questions related to this rare topic, please do ask your questions in the chat box, and we can pose those questions to Dr. Boszczyk. So next week also we have on every Thursday is what the meeting is being planned. Unfortunately, today Dr. Boszczyk had an emergency travel plan, and so we had to prepone this meeting to Wednesday. But henceforth it will be on every Thursday for the following 3 weeks, and we will be having international speakers and one more national speaker to do various talks related to trauma. Let me just call him to just check. Yeah.
So meanwhile, just to keep this forum active till they reconnect, we'll just go through what we have seen so far. So I'm Dr. Soma Sundar. I'm a spine and consultant in Kaveri Hospital, Alvarbet, part of Dr. Balamurali research team. So one of the go-to features in a cervical spine in a pediatric patient is the posterior spinolaminar line. Because as we have seen, there is obviously some discrepancies, and sometimes we may take it as a subluxation of the C2. However, the posterior spinolaminar line, if it is intact, then it is possibly a pseudo-subluxation. So many a times, because we don't see these kind of patients often, we might wrongly diagnose them to be a pseudo-subluxation. And this is where the spinolaminar line will come in place. And as Dr. Boszczyk has mentioned, these pediatric trauma fractures are very rare. And they usually present in various stages, various age groups. And it is always difficult to find out whether it is an epiphyseal fusion or the epiphysis or the delayed fusion or these kind of things, rather than a clear fracture line. In orthopedics, we usually find this by comparing bilaterally. If there is an injury in the hand or the elbow, better to take the opposite elbow, X-ray also, and compare it to see the epiphyseal fusion are similar. But in spine, being a unilateral midline structure, it is always difficult to find these. Yeah, Dr. Balamurali says correct.
Okay, so he'll be joining us in a minute. I think he's in hospital, and I think the hospital Wi-Fi is just kind of disconnected. So yes, he will join. So Soma, carry on. Sorry, go ahead.
As I was just mentioning about the difficulties in seeing a cervical spine X-ray in a pediatric patient and finding whether it is an epiphyseal gapping or a fusion or a fracture. And these kind of scenarios, as in the European and the Western standards, they always a little apprehensive about taking an MRI. But in our Indian setup, we have a very immediate access to MRIs. And when in doubt, and when because the child won't be able to explain his conditions, his problems very clearly as an adult. And when in doubt, we can always go for an MRI to confirm a trauma.
Sure.
And even in that scenario, better to keep the shoulder a little elevated, because the better to avoid the having the child's head touch the couch, because it will always cause a flexion in the neck.
So I think some of the points that he highlighted, I would say is, when young children come to hospital with pain or a clear history of a fall, the diagnosis is the most challenging. And in the conference, we have some discussion and talks about what's called as Shivora. So this is spinal cord injury without radiological evidence of any damage. So you can either have a ligamentous or a bony injury, or you can have a cord injury. And it's very important to differentiate that. And X-rays are, as was mentioned, is not always correct. The second thing is, it's very difficult to assess a child, assess the neurological status of a child. So we have to rely on radiological investigation sometimes. And especially in the setting when there is a normal neurology, when the child is not, when the child is moving the limbs, it is sometimes difficult. And many a times I have seen that children get discharged from hospital. Bronek, you're back. Sorry, you're on mute. Yeah.
I am back. Apologies, the hospital network failed for reasons I don't understand, which is, I'm very sorry about this. It
No
shouldn't
problem.
usually happen.
Yeah.
And I'll pick up from where we left off, which was the distractive injuries here. I was explaining about Deshirshensky's case. Okay. Are we still good?
We can't see your screen.
Oh, hang on. So it doesn't help if I don't screen share.
Okay, we're good to go.
You got it? Okay, excellent. So I'll just go back to this case. This is Deshirshensky's case. We had the child at 11 years old had a sledging accident with a distractive injury seen here, which he performed a craniocervical fusion. The tricky thing is positioning these children and actually approximating the head onto the atlas. And he did this very nicely, decorticated the atlas and the across this, and the child actually had a very good outcome. This is in the long-term follow-up with a solid fusion, but this, of course, is the exception in these kind of injuries. The second most common is the odontoid fracture, which in fact is, again, you can debate whether it's a fracture. It's a separation of the growth plate in situ. This is a fairly common injury. These can, however, be treated pretty much the same as you would treat odontoid screws in the adult. The kid's bone is far denser type of bone, and usually tapping into these works quite well. The lag screw doesn't work so well, but approximating these and getting these approximated is usually sufficient. It can be done from anterior or from posterior. The third entity, which needs speaking about in the craniocervical injuries, is the atlantal axial rotatory luxation. Now, I don't like the term subluxation because a rotation with about 60% of overlap, loss of overlap of the occipito of the C1, C2 joints is physiological. So it's only really the dislocation which is pathological, or the fixed rotation. If you leave these long enough, they will become fixed in place. This is the case of a 12-year-old kid with Down syndrome who was left in rotation for over 6 months, eventually required a peg feed because of the deformity and had respiratory failure. So once it gets this far and it's really rotated off, it gets stuck. Then it becomes difficult to reduce via traction, and typically surgery is the only option. Now, just reviewing the C1, C2 joints, it's important to understand that these are biconvex joints. It's the only large biconvex joint, and there's a very large range of rotation, which the alar ligament actually restricts. So the C1 subsides on C2, and as it rotates, the alar ligament wraps around the odontoid process and restricts the motion. So the physiological range of motion actually allows rotation to a minimum of overlap of the joint. So this is physiological. Once it gets beyond this, it becomes a problem. In such cases, pretty much surgical release and fusion is what is required to reduce these children. Now, there's a couple of pearls in this. And there's two different ways of placing screws in C1. This is the standard situation is placing them in the Margol and Harms technique, which is through the posterior aspect of C1. And the posterior aspect of C1 is often compromised of a very significant venous plexus, which one needs to work around, as well as the C2 nerve. It's not easy to get screws into this bone. So what is required is an exposure of the posterior aspect of C1. This is the arch of C1. This is the vertebral artery. And a key aspect in this whole surgery is taking a high-speed burr after having coagulated the nerves, the veins, and with a high-speed burr just to perforate the posterior cortex. That allows a tap to be inserted into it, and then a screw. Trying to push this freehand with an awl, this bone is so hard, the bone will just move away from you. So it's a very careful, through the posterior cortex with a high-speed burr, tap it, get a screw into place, and then one has control of the craniocervical junction. So this is where the screw goes. Alternatively, in older children, it is possible to go straight down the pedicle. So nip off the back part of the arch and then go straight down the pedicle here with a high-speed burr again, and the screws go into this, and this provides very good purchase also for atlas fractures, but of holding these two together. This is an example of a child with a fixed rotary subluxation, which failed conservative treatment. Here it is seen in the rotary position. The child was on halo traction, but anytime the traction came off, he would just resubside into this. If one gets some fresh halter traction, will do halter traction and either a brace or a collar or even a halo for 2-3 months will work, but in some cases they just keep relapsing, and these it makes sense to perform the fusion. The other technique for a fusion, if it can be realigned, is a C1, C2 fusion. There are cannulated systems like this with which this can be accomplished. Working as a surgeon team, very important, especially if you do not have navigation. The assistant places a Penfield dissector just medial to the isthmus, and the assistant's job is to guide the surgeon into the medial lateral convergence of the drill bit. The surgeon himself is paying attention to the fluoroscopy to get the trajectory correct, to just get through the C1, C2 joint. So this is a very good way of enabling this with one C-arm and no navigation, which often in the child is difficult because the C2 spinous process is still cartilaginous. So not very reliable navigation. This is a good way of doing this. This is what it looks like afterwards. I like using these 4-point fixations. Ulrich makes these systems where you also have a clamp on the end of the rod with which you can fix C1 and bone graft across the two of them. This is the long-term follow-up. This child after 6 years who remains stable. When fashioning the bone graft, the C2 spinous process is notched, as is the graft. The cortical shell is kept on the outside, and there needs to be an overlap of the cortical shell towards the posterior rim of C1. So this buttresses against C1, so that when tensioning this, I use Ethibond, not a wire. One prevents pushing the graft into the spinal canal. So it's a bit of carpentry. Notch into the graft at the bottom, keep the cortical shell posterior and overlapping onto the arch of C1. Compression injuries. The typical Jefferson fracture is a rare thing in children. It tends not to happen. The important thing, of course, in Jefferson fractures is whether the transverse ligament is competent, either because the ligament has an injury or because the ligament has avulsed. Those are the two in which the atlas can migrate on the odontoid. They are pretty uncommon in children. This is one of the few examples I was able to find in a child where the child was hit, but as you can see, the odontoid is very well contained towards the arch, and the transverse ligament will be deemed to be intact. These heal very well conservatively. They do not require surgery. The key aspect is whether the transverse ligament is intact. In adults, you do an open mouth view to assess for the overlap of C1. In children, this is almost impossible to get reliably. So CT, MRI are the imaging of choice. The odontoid fractures, as we had discussed, the most common site is the C2 synchondrosis. This is where most of these tend to happen, but they do usually heal quite well. The aspect which is more difficult to deal with is a spondylolysis and differentiating the pseudoluxation from a true traumatic spondylolysis. Hangman's fractures, again, are very, very rare in children. Swishock's line is the criteria which was developed in order to differentiate these, along with the posterior alignment of line of C2. A line drawn behind the body of C2 should touch but not intersect C3. So it's always a very good idea if this is aligned here and it doesn't intersect C3, then typically a significant injury is not present, as well as facet joints overlapping well. And Swishock's so-called line, which is a line from C1, touches the cortex of C2 of the lamina and C3. In a Hangman's fracture, if the pedicle actually has been injured, then these two separate as in this image. So then the posterior arch actually separates from the line, indicating what is obvious in this case, the Hangman's fracture with the injury of the C2 pedicle. Now, usually this would also go hand in hand with a disc injury, but it does not have to. Compression injuries, very difficult to assess. Again, if one looks at the AP, it's a pointless investigation with all the very thick, soft tissue that is present compared to the adult, where one would assess the prevertebral shadows, the step off into the subaxial spine, the anterior line of vertebral body's posterior line, and the line of the lamina. All these are clearly visible along with the square shape of the vertebral bodies. In children, the vertebral bodies are not square-shaped. This is a 4-year-old from a sofa. These are slightly wedge-shaped. This is physiological. This is not a fracture. They very rarely sustain fractures. Here there's pseudo-subluxation, and the step-off in the soft tissue can be masked. Typically, if there's a white shadow in front of C2, it is pathological though. So this can happen. Just again, the comparison to the adult spine. Often in the pediatric spine, the wedge-shaped bodies are also accompanied by the ring apophysis. So having a small ring apophysis, that's the ossification center of the disc, is a physiological finding. This is not a fracture. The distracting injury is the more common. So there's a typical picture, 5-year-old passenger in a car, comes into A&E. This is just a fluoro shot across the, doing the assessment of the stability after the child has been tubed, and these typically separate. This is a fairly common finding. And the separation, the injury is usually with the end plate coming off the vertebral body. This is an image of Rashni which shows us very well. This is the most common type of injury pattern in a distracting injury. This is a case I would like to share to show how misleading these injuries can be. This is an 18-month-old infant, and the parents were involved in a reasonably minor MVA. The child was thrown out of the car seat. On admission at A&E, the child initially moved all 4 extremities, then developed decreased alertness and was intubated. Now, the reports clearly say the child was moving. Whether it was or wasn't isn't entirely certain. This is the trauma scan, and the scan was read as normal by the on-call radiologist. If you look carefully, you can see a slight separation here, and you can see a slight widening here. All this is actually physiological, but it's pretty hard to make out if you're not a seasoned pediatric radiologist. Also, the prevertebral hematoma, there's nothing much to see here. So this child was taken to ITU for further treatment, was weaned off the ventilator, and after discontinuing sedation, the child woke up and was tetraplegic sub C6. So an MRI was obtained, and the MRI shows exactly this: the separation of the vertebral body at the level of the end plate. The posterior ligaments are torn. Actually, very, very small prevertebral hematoma. So this explains why even on CT there's a very small soft tissue shadow, but a clear spinal cord injury. The emergency measure, which then was taken, unfortunately, by the on-call team, was to put the child on traction without any further measures, and several kilos of traction were applied to the spine, which, of course, creates traction across the spinal cord. So these children need very, very gentle traction. If anything, placing them on Gardner wells and traction, then taking the imaging is not ideal. So we need to be very, very guarded with placing these children on traction. If one places on traction, fluoroscopy needs to be in place. Gentle manual traction first and thereafter. But a full bicolumn injury is not sensible to be placed on traction. So this child was fixed with an anterior-posterior procedure, a modified hand plate from the front, and posterior cerclage at the back to fix this. The child has done well, but has remained tetraplegic. And this is the typical pediatric halo. These are special pediatric pins which are blunt. If you don't have these, you can have 4-point fixations. You can have 8 pins which you place into the halo if you don't have a special one for small children. It makes sense in these halo vests to put a strap through between the legs to mount on the front and the back of the halo vest, because this is very convenient to move children around with, and children do tend to slide out of the halo vest if they're very small. So this can happen. Surgically, getting to the cervical spine in these small kids can be somewhat challenging. It is the same as adult spines, only the thymus is a very large gland in the child. So be prepared to encounter this. It is not the thyroid gland. The thymus comes up from under the sternum, and this can be in the way. It just needs to be dissected down, and then the approach is pretty much as one would have. The next case is a very common injury in children that one sees, and I know numerous surgical colleagues have tried to treat these in different ways, and we've all ended up with the same result. So this is a 12-year-old kid after wrestling. So he comes in with a stiff neck. This is the X-ray in the vacuum mattress, and we can see the slight angulation here. On the MRI scan, there's an isolated posterior ligament injury. Nothing else going on. The child is otherwise neurologically intact. This is guided extension flexion view. So traction is the first view. Traction is stable. Extension, flexion, and in flexion, there's a widening of the spinous processes here, indicating this ligamentous instability. But in reclination, it reduces entirely. In a hard collar, the spine is entirely maintained. Now, the initial thought was to try and treat this conservatively, see if the ligaments would heal. After 3 months, they do not, of course. So these ligaments in children do not heal very well. The next attempt was made after reducing this child, and this is the actual damage one can see here with the facet joints actually, the capsules opening up, is to provide a cerclage around the spinous processes with PDS. This was the initial thought, and this resulted in a very nice alignment. But of course, this is not a fusion. And again, after 5 weeks, this failed, and the child ended up with a posterior fusion. This is an old case where we still use these types of plates. And I know of multiple surgeons which have tried to treat these in a functional manner. All surgeons I know with this type of injury ended up with a short segment fusion. So it seems to be of little avail to try to treat these ligaments, to get these ligaments to actually repair themselves. The compressive injuries are rare. When they do occur, pediatric bones don't fracture and split the way adult bones do. You get more of a compression and impaction that changes the configuration to wedge. This is a 15-year-old, and you can see is already the shape of the vertebra is pretty much box-shaped as in adults, and the compression results in a wedge shape, but it doesn't result in your typical teardrop fracture or burst fracture as you would see in adults. These can be treated conservatively. If they fail, it is a reasonably standard procedure with an Alicrest graft and a plate, and these usually do quite well. They are, however, quite rare. I've never seen one in a younger child. In the adolescent, you will see these. In the younger child, by far the soft ligamentous injuries dominate. So in conclusion, pediatric cervical spine injuries, fortunately, they're uncommon. The experience is limited. Over the years, one does gather some of these. They are obviously best pooled in centers which see a lot of trauma or where advice can be taken. Typically, the injury is in the synchondrosis or the ligamentous attachments. They can be difficult to diagnose. MRI obviously helps substantially in these days. And the functional fluoroscopy, I really like relying on traction, extension, flexion, is a very useful tool to assess for instability, because these can be quite unstable in true ligamentous injury, so they can be quite severe. So as Bala had kindly invited me to indicate NSpine, we have 2 master classes come up, which is 6 hours of case discussion a day. One is in Arosa in Switzerland in December, and we discuss all topics, 6 hours of complex cases. We have one coming up in March in Canada, same format, 6 hours of case discussions a day. And then we have a multidisciplinary conference, which is a typical multidisciplinary discussion of lectures, cases, and surgical techniques, which will be in September in London. I would like to thank you again for the very kind invitation. I think this is a fantastic format, and it's my honor to have been here, and I'm available for any questions which you may have.
Thank you very much, Bronek. That's a very interesting talk, and obviously, as you said, it's so rare that you had to compile this talk with cases from various people. And, over the last 20 years, I have probably just dealt with one case of an injury where we had to actually intervene surgically. Now, Soma, are there any questions? I have a few questions. Any questions in the channel chats?
We are just putting it up, sir. So we are getting some questions. Meanwhile, you can go ahead with your questions.
Yeah, sure. So Bronek, one thing is, we have classification systems, the various AO classification T-leaks, and in pediatric, yes, it's very rare to devise any classification system. But are there anything available, any scoring system or classification that's available to validate or to guide us into diagnosis and treatment?
I honestly haven't updated my literature searches in this respect recently. I'm not aware of any. If there are some, they must be pretty recent. I think these entities are so rare that a validated classification, I believe, doesn't exist. If you were to classify them, these are all type B injuries. In a way, they're all ligamentous distractive injuries. The compression injuries simply do not apply. And you can debate, of course, whether, an avulsed alar ligament from the tip of the odontoid, whether that qualifies as a type 1 odontoid fracture it's not the same thing.
Same
It's
thing.
an
Yeah.
avulsion which has come off. So I think these really need to be taken on a case by case basis. But the area of least resistance is where the bone grows, because the bone has to grow. The growth plate has to allow for the tissues to separate to a degree, and this is the area of least resistance. This is what is prone to injury.
Yeah. So I remember seeing a few cases of and purely isolated cord injury alone. The Shivora kind of picture. So
Yes.
what would you say, because there's a lot of young people here in the forum, what are the red flags when we see a child, and commonly we see with our Indian population, you have kids jumping off the bed, and you have patient in the emergency, or while in sports, the kids bumped into each other, contact sports. So what are the red flags that we should watch before you say, okay, it's just an injury? And what do you use? What is a logical way of following them up?
The Skewara obviously goes hand in hand with neurological injury. A child which attends and has a neurological deficit requires an MRI investigation. There is an entity which I have not included here, which is very rare, which is you can very rarely get cartilaginous embolization of the pediatric cervical cord. It's a rather complex mechanism, but it has been described. I've never seen a child with this, but it has been described. And due to the vascularity of the end plate, in some fractures, you can get an embolic occurrence. And any of these require MRI imaging. The shaken child, the Skewara, if you have a history of children being shaken, and if the child does not exhibit normal activity, the upper extremity, lower extremities, it's not grabbing, it's not holding, I think there should be a relatively low threshold in obtaining an MRI investigation. If kids move normally, there's not gonna be something. I mean, the case I showed with the injury, where the child was intubated, there's a lot of debate whether this child really moved to full extremities. This is the way it was recorded. I think if in doubt, the threshold and the mechanism fits, the threshold should be reasonably low to obtain an MRI scan in this day and age, because children are poor historians. You often do not know what really has happened. And you can miss these injuries. It is better to get the MRI scan. One thing, children do not like to be mobilized. If the child is sitting itself up and has full head control, it's pretty unlikely there's going to be a significant injury. And this is one of the evaluating things in a child which is cooperative. You can ask the child just to lift the head off the mattress, and that is a good indicator. If your plain X-rays have been reasonably normal in a somewhat older child, the child can lift it. That's a good indicator that there's nothing serious going on. So head control, it doesn't factor into any of the classification systems to my knowledge, but good active head control is a very good indicator that there's nothing serious going on.
Yeah. And on one of the cases that you showed, this 12-year-old with an subaxial injury, where you first tried conservative and then you tried with the PDS, and then you
Yeah.
went up and did an instrumentation. So now would you say that when we have a suspicion of an ligamentous injury in children, they would directly just go in and do a fixation?
So I tried this. I know that Michael Blout tried this. I know Paul Heine tried it. I know a whole bunch of people, because you really just want to fix this. You don't want to fuse this kid. So I know a number of experienced trauma surgeons who've tried to somehow get these ligaments to adapt. They don't. And so in my books, if I had this again, I would go straight for one single segment fusion, find the level which has the injury, and fuse that level. All the surgeons I've spoken to have had the same experience. It's very, very hard to get these ligaments to reunite.
Soma, any questions in the group?
Yes, sir. We have one question here.
Yeah.
So the question is, we're asking how significantly different is pediatric spinal cord injury recovery compared to an adult of the similar injury pattern?
Yeah, kids have a way better prognosis. So unless it's an infarct, unless you have a anterospinal artery lesion and infarct, they do tend to recover much, much better. We've had kids which have had significant deficits initially and have recovered quite well. Now, that said, this child, which I showed the case of, which was then distracted, she remained tetraplegic. So I think there are exceptions, but overall, children have a way, way better prognosis. I have seen children who've had very good sensory sparing and have not recovered fully motor-wise, so it does happen. But generally speaking, the plasticity is way better. Also, they're not as dependent on a high perfusion pressure, I think, as adults are. So it is somewhat easier to manage them and keep the perfusion pressure going.
Sure. So, Bronek, in terms of instrumentation, there's a big challenge because we don't have anything for them. So, what are your salvage options? What do you use?
Yeah, so in the very small child, it literally is the sutures around the soft tissues and ligaments. These trying to in the under so a 4-year-old, 5-year-old, you get reasonable fixation, also from posterior. In the smaller ones, the 2-year-olds, it really depends. The lateral masses don't tend to work well. You can get pedicles if they're reasonably big. If they're not, the sutures through the soft tissues are quite helpful. And otherwise, you have to, as we did for that child, you can deviate to other, usually it's small hand implants, plates and screws, which you can use. But the purchase on these is not fantastic. It's fairly dainty screws. I do like to back them up with sutures through the soft tissue. That does seem to work quite well. The vertebral body for anterior fixations, the vertebral body is reasonably good. The vertebral body you can get pretty good purchase into. But again, the plates are often too large. The conventional adult plates are too large. And we've deviated to using hand plates for the really small kids where necessary.
Sure. Thank you. Soma, any more questions?
Sir, I have a question.
Yeah, Keerthi.
So, if you offer conservative management and immobilize with a brace or a halo, what is the expected period of immobilization?
So I typically use 10 weeks. I mean, you have some bony consolidation after 6 weeks. I just like to keep them in 10 weeks, usually to see that this really works out. Yeah, I don't think you need to go the full 3 months, but 10 weeks is my personal preference.
Okay. The follow-up we need to do, I mean, dynamic CTs or dynamic X-rays or just plain X-rays, for example.
So it depends on the injury. In conservatively treated craniocervical instabilities or aspects like this, I do tend to take them out of the halo, then do extension flexion views to see that there is no obvious excessive range of motion will be concerning. And after extension flexion views, if these are normal, I would then allow the child to progressively partake in the activities needed. It depends on the reason what one is treating. If it's a halo for a torticollis, which one is placed, then I tend to wean them out of that very slowly. I try to avoid a halo if possible and use a stiff neck, which incorporates the head. And these I will wean out of it slowly. Take the collar off and start with the extension flexion, avoid the rotation, the last thing which comes, and then in a graded protocol, start to get these children back into their function. Because there is a certain danger that they'll relapse. And that is different from a child with an odontoid type of fracture, which if you have union, you have union. That is far easier to deal with than the ligamentous injuries.
Thank you. And one more question, sir. So you have done posterior fusion in one of the cases you have shown, sir, that facet fusion in the posterior aspect. Does cervical spine behave similar to thoracolumbar in case of this crankshaft phenomenon with the growth? Can there be any rotation deformity in cervical spine also, sir?
Yeah, in these short segments, it doesn't seem to matter. It does not seem to be a major problem, the short segment fixation. So I haven't seen any particular deformity problems there. Also for the anterior part, The anterior spine, if it's a separation of the end plate, you don't need graft. You just put the plate on. I didn't mention that. You can put the plate on, the end plate reunites, and you can take that plate out after about 3 months. That can come out, and that growth plate is usually healed. So you don't have to take out the whole disc and create a fusion for that.
Thank you, sir.
In a posterior cervical fixation, sir, especially in a very young age group patient, less than 6 or 5 years old, when do you, and if so, when do you or will you advise and counsel for a later implant removal, especially in a screw fixations with a rod, with restricting the growth?
So it doesn't seem to be much of a problem. This is the same, if you're doing thoracolumbar deformity and you remove a hemivertebra at the age of 3 or 4, it doesn't seem to cause much of a problem. Michael Roof has followed these extensively in his very extensive practice and has done some very good work where you can see the vertebral body grows around it. He very rarely removes the implant. Certainly we don't. That said, it's not problematic to remove these if needed, but it doesn't seem to cause much of a problem with regards to the presence of the metalwork. These segments which are fused obviously don't have the same growth expansion that the adjacent levels do. So they do remain a bit shorter, but it's not that the bone, increases to grow and the screws start cutting through. That doesn't seem to happen.
Thank you so much, Bronek. I think that was a really very interesting talk, a rare problem, and you just showed a lot of highlight and insight into it. We thank you so much for taking time off your
You're
busy
very welcome.
schedule. And we look forward to meeting you soon in London next year.
Perfect. We look forward to it. Excellent.
Thank you.
so
Thank you,
much.
Bronek. Thank you all. Thank you so
Thank
much. Thank the viewers.
Thank you, sir.
Bye-bye.
Bye-bye.